All right. I am David Darrow from the University of Minnesota, leading the Joint AANS CNS Pain Section Guidelines Committee. And we're super excited today to be here with Dr. Malhotra.
Thank you, David. This is Ajay Malhotra. I'm a neuroradiologist. I work at Yale with interest in trigeminal neuralgia, hemifacial spasm, and its imaging. Thank you for having me.
Thank you so much. And we also have Dr. Sokol here.
Hey, how are you? Vishal Sokol, functional neurosurgeon at Westchester Medical Center in New York. And
so thanks so much for being here. Our goal today is to talk about trigeminal neuralgia, and we're talking about, essentially the push for the first ever surgical guidelines for trigeminal neuralgia. We're hoping that eventually it'll turn into more than just surgery, and we can have all the societies have their components of, for trigeminal neuralgia. I know we already have, there's a lot of work being done right now in the headache societies and for diagnosis. And I know that you guys are doing a lot of work on the radiology side. And so now finally, I think we're just trying to get the first version of the PICOs out. And most of our PICOs are really about comparative effectiveness of surgery, which makes sense since, we're surgeons. But there is one very specific PICO that looks at imaging because, as we've talked about, imaging is not only critical to treatment and diagnosis, but is actually baked into the diagnosis of classical trigeminal neuralgia or idiopathic trigeminal neuralgia.
Yeah, so we do perform imaging, and I think this is a very timely effort to come up with guidelines, assess the effectiveness on how we are using imaging, both for classic trigeminal neuralgia, where you're suspecting a vascular cause for the etiology, but also making sure the imaging is including other sequences or other, so that we can exclude the secondary causes of trigeminal neuralgia. So as important as it is to find a vascular conflict and recognizing that MRI can help, but there are many cases where MRI may not show it and it would still require neurosurgical evaluation. But both for the vascular causes, but the non-vascular secondary causes of trigeminal neuralgia also, I think it's important to keep those in mind and come up with standardized guidelines.
That's awesome. Historically, MRI has been a pretty big aspect of trigeminal neuralgia for basically since it's, became a thing in the 80s. And now the imaging is so beautiful. But I'd say that, even in, the way that we're classically taught, MRI has always been very specifically talked about to rule out a whole host of secondary, causes of trigeminal neuralgia. And sort of like you brought up in the past, despite all these different ways of damaging or injuring or annoying the trigeminal nerve, everybody presents with a pretty similar phenotype.
Right.
This sort of sharp shooting pain in the face that can be in different distributions, but is distributional and dermatomal. And so it's really interesting that you can have things like a schwannoma, or you can have things like multiple sclerosis with plaques in the pons, and you end up with the exact same symptoms.
Right. Absolutely. Whether it's a secondary cause, multiple sclerosis tends to be one of the more common causes. Any kind of a dental manipulation, tumors, schwannomas, in practices with a lot of head and neck cancers, perineural spread along the fifth nerve, vascular lesions, vascular malformations. So all of those things, or say dural-based pathologies or bony hyperostosis, like right next to the trigeminal nerve, all of these can present in a very similar manner. And imaging, when we talk about classical trigeminal neuralgia, we tend to talk about the high resolution 3D imaging to look for a vascular conflict. But it's also important to keep in mind there are many other entities which can present in a very similar manner.
What's been sort of the evolution, I guess, on how you guys have thought about the sequences for MR and sort of how they've helped? Because I think now, there's some variation between centers, but that's mostly just like marketing and branding. But now, like, it's just so advanced that we get so much information.
I think most, if you look at the literature evidence and what practices, most practices are trying to do now is some sort, and again, the names might be different because of the vendors have specific different names. But basically, what's recommended is a high field strength, preferably a 3 Tesla scanner, doing high resolution 3D, heavily T2 weighted sequences. So these come with different forms, different names. The common ones are the constructive interference in steady state, the 3D FIESTA, the T2 space. So these are all some form of 3D imaging. The benefit is it's a very thin section, it's sub-millimeter, so very high spatial resolution, and also the ability to reconstruct in different planes, because you want to be able to see the neurovascular conflict or what's happening to the cisternal segment of the trigeminal nerve by moving it around, like doing MPRs and making sure you can see the whole length of the trigeminal nerve. So that has almost become integral to the evaluation for trigeminal neuralgia patients. But in addition to these, like doing the basic sequences, like you said, patients with multiple sclerosis, so having some kind of a FLAIR. And for multiple sclerosis patients, how it has evolved is we used to do the 2D flares with a slice thickness of 3 millimeters. A lot of centers and most scanners are now giving that availability. You can do 3D FLAIR imaging. So again, very high resolution and with a fine matrix. So the whole idea is to keep the spatial resolution as high as possible. Also recommended is time of flight MRA. Also, although like I would say, like in the literature, there is very little, like now with the high resolution 3D T2 imaging, do we really need time of flight MRA? At least in my personal experience, you can trace the vessels. You can almost always go back and look at the vessels. The benefit used to be, are we looking at arterial versus venous structures? The time of flight MRA might be able to help, but that's a very rare instance. Most of the times, you can see on the 3D T2 volumetric imaging what vascular structure, and you can see, like, is it connecting? Very frequently, it's either the anterior inferior cerebral artery or the superior cerebral artery. Even if it's the venous side, the superior petrosal, like you can often trace it. So very rarely do you need MRA, dedicated MRA sequence for that.
Right. What do you get, Vishal? What do you usually get out of yours?
I think mostly what we do is, just a high res T2 FIESTA or I think the space 2D space, the space image. It's one of the two, but I've mostly personally relied on the high field stuff. Occasionally I'll get a CTA, but sometimes a little more for intraoperative planning for surgery, just for registration, finding the sinus, things along those lines. I don't know. I feel like sometimes the resolution isn't as good. The CTA is usually pretty solid resolution, but sometimes I have trouble kind of registering those to really kind of get a good 3D view, sort of the imaging. And I know that now that most of us are using 3T scanners, right, for most of these things, we've kind of fallen away from needing, at least in my experience, we've fallen away from needing a time of flight MRA.
Right.
I guess as we move into more, do you still recommend that for centers that are still using 1.5 Teslas or maybe getting their scans out in the community as opposed to at an academic center? Do you still recommend MRA in those settings, or do you think the imaging technology itself, even with 1.5 scanners, has evolved to the point where we kind of really don't need that any longer?
There's very little in the literature. Like, have people done studies to assess is time of flight MRA needed on 1.5 Tesla? There is very little evidence for it. But even with 1.5 Tesla scanners, you get pretty good, decent imaging quality. As far as as you mentioned, the main drawback of 3D imaging is when the patients are moving. When patients move, because it's a volumetric slab, the whole image data set gets corrupted. So you don't really get a good look. So all the images look blurred, unlike 2D imaging where you're acquiring slice by slice. So, but again, 2D, you cannot go that thin. So we rely on 3D imaging. But sometimes when patients move, it becomes an issue. As far as CTAs, sometimes they do help, especially when there is a bony pathology or you're trying to assess the petrous, especially there is petrous exostosis or there is bony hypertrophy in those cases. For the vascular part, at least in my experience, I find a 3D heavily weighted T2 typically gives most of the information, and even with 1.5 Tesla scanners.
Yeah, we've recently, in our practice, people get MRIs all over the place, and they do try to do, heavily T2 weighted, but I struggle. Maybe I'm not a radiologist, so I struggle. I mean, I look at a lot of these scans, but I struggle to really make things out when they're not done at our center. So I'm very picky because, I want to really clearly see what's going on if I'm going to cut someone open. And so I pretty much always make them get a new scan. And we just recently switched to 7 Tesla after a lot of testing. And man, I got to tell you, they look amazing. It is just ridiculous how.
I'm very envious right now, David.
It is. I mean, like we've only done a few, but every single time I look at them, it is just ridiculous how amazing, And we do 7 Tesla sometimes on the because Vishal and I are stereotactic and functional, so we do DBS and other things. And our struggle with 7 Tesla is that there's just so much. I mean, it's hard to register it to anything else because it's just it's impossible to get it super clean. But for this, it just gives such beautiful images of the cranial nerves.
Again, the stronger the field, and it's not just the field strength of the magnet itself. It also depends on the gradients and how the sequences have been tailored. So when we get images from other sites or from peripheral sites, one of the more common issues is that it has not been tailored for the trigeminal nerve. Many people very frequently have protocols for the internal auditory canals. So the angle that they're doing, they're not really angling it or trying to include the whole full extent of the trigeminal nerve. And that, makes it very difficult because instead of assessing the full strength, the full length of the cisternal segment, you get a look at a very shortened segment. So that makes it very hard for evaluation. So again, it's some of it is the field strength, the gradients, but also if places have tailored their protocols specifically for the trigeminal nerve.
Yeah, it probably took us 3 or 4 years to get that protocol just right. So it's a lot of work, but I think when you have it, I mean, if it were my family or if I was a patient, I mean, I think getting such a clear view like that is just so helpful because oftentimes the coronal reconstructions are actually the thing that tells me the most about what's going on. I can usually see it on the axials, but when I have the coronals, I can really see exactly what that nerve is feeling. I mean, you can do it along the nerve as well, but the coronals are pretty good for that. And I can see what's going along the nerve as it's making its way through the cistern. And that, it tells me the dynamics more than most things. And I just can't do that unless it's, a real nice picture.
And just wanted to point out, some places are doing the 3D heavily T2 weighted images, but they're not isotropic. So if they're not, then your ability to do reconstructions, not just the coronal and the sagittals, but also along the plane of the trigeminal nerve becomes very limited. So practices which are doing it have to make sure they're doing it in an isotropic manner.
So I think that's what our PICO is sort of is centered on for the radiology, which is essentially, should we be getting, if for diagnostic purposes, should we just jump right to the dedicated, high resolution, heavily T2 weighted that we all know, that we all use these days, or should patients start out with a screening regular brain MRI? That's sort of, one aspect of the question that we're sort of throwing out there.
I think having some basic MR brain sequences are very helpful, especially if you are trying to exclude the secondary causes for trigeminal neuralgia. So having at least some form of FLAIR imaging, preferably 3D FLAIR imaging, so that you can have a look at the brainstem, at the trigeminal nucleus. I think that's very important. Some of the other causes that we see fairly frequently in practice that present in a very similar manner are patients who had recent or not too long back dental manipulation. So having sequences where you can assess specifically the enhancement part along the V2 and the V3 distribution. But it's uncommon to have V1, but every once in a while you'll have patients
Right.
with other pathologies, which are whether it's the cavernous sinus, the superior orbital fissure. So yes, the yield might be low, but if you are trying to do a comprehensive workup, at least having a FLAIR and having thin section post contrast images of the brain, but also making sure we are including the branches of the trigeminal nerve, the more distal part. And in busy practices where there's a lot of head and neck cancer patients, of course, assessing for perineural spread as well.
How often are you seeing, obviously we see things from the neurosurgical perspective. We're getting a patient who's coming to us for evaluation, potential surgical evaluation, or maybe it's a new diagnosis or things along those lines. And you're obviously seeing things from the radiologic perspective where scans are coming across your desk with this rule out trigeminal neuralgia sort of question mark. What percentage of secondary trigeminal neuralgia type pictures are you seeing from a radiologic perspective compared to, say, what we see on the neurosurgical side?
So I would say there is, again, I think we need to do a registry, because in my experience, going back the last few years, we see it not infrequently. And one of the more frequent causes is, again, as I said, in addition to the known causes, vascular malformations are pretty uncommon, and at least in my experience or as per the literature. But some of the other causes, especially the dental procedures, the demyelinating lesions, adjacent dural-based lesions, we see them. It's hard to again quantify because we have not assessed it going back, but I would say around 5% of cases do have a secondary cause. I'm not sure if that's what the literature evidence suggests too. And some of the other causes which are not as well documented in the literature that we have started seeing or appreciating, we have had a few cases of idiopathic intracranial hypertension presenting with trigeminal neuralgia. So again, this is just coming up in the literature. There are isolated case reports, an absent or a very hypoplastic Meckel's cave where there is barely any CSF around the trigeminal nerves. So vascular causes, and again, it's known fact that many times vascular causes may not be seen on MRI. But instead of being very fixated on just the vascular etiology, it's also important to make sure we are not overlooking the non-vascular causes for trigeminal neuralgia.
Right. I think one thing that maybe people don't realize is that the imaging has gotten a lot better. So I think you guys have gotten very specific about how you're looking at the neurovascular conflict, because historically, if you just looked at neurovascular contact, the incidence is extremely high in the population. And so, I think people, it's important to understand that having vessels near the trigeminal nerve is not uncommon. Seeing markers of compression is uncommon, where you're actually seeing the nerve change course along its axial dimension. And I think it also points to a little bit to mechanism, which is just touching the nerve does not cause trigeminal neuralgia. But perhaps there are people that are more vulnerable to having interaction, with a vascular loop that present with trigeminal neuralgia. Because I've certainly seen very severe looking neurovascular compression and no symptoms.
Right. So, like you said, vascular vessels abutting whether it's the seventh, eighth nerve, or in this case the fifth nerve, we see them fairly frequently. The contralateral side also, like patients present with symptoms on one side, but you see the vessel on the contralateral side. And some studies have done looking at the volume of the nerve, like if there is atrophy over time.
Right.
But it's hard to tell, like during the disease process, like how chronic does the process have to be for the volume changes to show, and is it reliable? So patients who don't have long-standing symptoms, can we use those metrics? So that's why it's not routinely done in imaging practice. But again, these are very helpful features when there is morphological change, signal change in the cisternal segment of the trigeminal nerve, or if there is clear sign of atrophy. And of course, the distance from the root entry zone, like is it closer to the root entry zone versus more distal? Because like at the entry to the Meckel's cave, you see vessels not very infrequently.
Right. I think people I see all the time on reads, vascular contact at the porous.
Right.
And that's just, sounds good, man. But I've that's never really correlated at all with,
Right.
symptoms for a lot of these patients, which is interesting because like you sort of mentioned, I have seen patients who have weird congenital, things going on with Meckel's cave, the size of Meckel's cave or the shape of Meckel's cave or the shape of the posterior fossa. And they seem to develop, some aspect of trigeminal neuralgia that honestly is typically pretty refractory, to most
Right.
of our treatments.
And like one thing I didn't mention when we think about secondary causes, also looking at the temporomandibular joint, it's a synovial joint, synovial pathologies. We see degenerative changes all the time. But if on imaging, especially if you're giving contrast, if there is a sign of synovitis, if you are seeing like an acute process, an acute inflammatory, that's more suggestive. Degenerative changes per se is not like we see that in patients all the time
Right.
and does not really correlate with a patient's trigeminal neuralgia. But when there is an active sign of synovitis, we have seen cases where patients presented primarily with trigeminal neuralgia.
That's interesting. One of my colleagues here is a big part of our facial pain clinic on the dental side, and he is involved and does some dental MRI.
Right.
And it seems like that's like kind of like a new, imaging teeth and imaging. And we've done some DTI work for, tracing through the face, and we found that really cool. I don't think it's quite ready for prime time because it's
Right.
challenging to do, but it is very cool. So maybe that's one direction, like you're pointing out. You're probably going to catch, the TM joints, with most of these scans. Probably not the teeth, but maybe at least some of the teeth. And then you're most, we catch, I think, most of the course of the nerve peripherally.
Right. So, sorry, go ahead.
As I was saying, I don't know how much our scans catch a lot of the peripheral course. A lot of times they're just it's an MR brain with the add-on. I feel like most places it's an MR brain with the add-on to focus on the IAC or some sort of a trigeminal protocol. And obviously, David, you have a little bit more of a honed-in protocol that you guys use. Ajay, would you recommend developing for the average neurosurgeon who's doing trigeminal neuralgia surgery, be they functional or not, or has an interest and does a lot of these, would you recommend developing like a specific protocol to capture both the, obviously the proximal as well as the distal and peripheral aspects of the nerve for evaluation?
So we have, David had mentioned patients getting referred from other places and repeating the imaging. So if our clinic is sending the patient for trigeminal neuralgia, we have started including in all patients thin section high resolution imaging, which looks at the V2 and the V3 segments. So the whole course of the inferior alveolar nerve coming out to the mental segment. So we routinely on post contrast images, thin section 3 millimeter slices, we have now started including because sometimes that history is not available to us when we are scanning the patient. And because we are seeing so many more patients with dental, any kind of a dental work, orthodontic, dental extraction, these patients are coming. And it's not infrequent to see asymmetric enhancement along the V3 segments. We also see cases along, I had a case yesterday, the maxillary nerve, the foramen rotundum showing enhancement. So routinely we have started including thin section in addition to the whole brain, making sure we cover the mandibles, so both the V2 and the V3 all the way to their distal segments. DTI, studies have been done. Some people have looked at DTI at the main trigeminal nerve also. The issue is it's very very difficult to perform in a consistent way. Yes, the ADC values, you can do the FA values, but to do it in an accurate, consistent manner is very, very difficult in real life clinical practice. In the research labs, it's a different issue, but for real life clinical practice, it's very challenging.
I think you have to spend so much time seeding it that invariably with your eyes, you're doing the DTI sort of manually because you're following it through every single, aspect of the nerve. So it's more of an exercise than it is a product. Just how much time are you going to spend, in every plane trying to like pick out, the inferior alveolar nerve through the bone. But, it makes really beautiful pictures. And I think we've been wondering, just like you're seeing, like, can we pick up any of this pathology in any other way that we assume is going on? The incidence of dental issues and the incidence of TMD is just thousands of times higher than it is for neurovascular compression, in these patients. So, if it could help with diagnosis, that would be amazing.
Again, I think people have tried, but so far at least, it's not reached the point where it can be incorporated into clinical practice.
Totally.
Mm-hmm. What are you guys seeing for those patients who develop more of the trigeminal neuropathy? Obviously, some of this is post-dental, some of this is, but kind of from the sort of in that subset of the TMD type patients. What sort of like, what are you seeing come across your desk in terms of scans with patients that are more trigeminal neuropathic pain as opposed to a classic trigeminal neuralgia? Because we see a lot of that, and obviously, something that we've talked about is developing these PICO questions too. It's just sort of in the process of identifying these patients for surgical candidacy, making sure you're picking the right patient as well. From a radiologic perspective, beyond neurovascular contact, what are the things can we keep an eye out for?
So, the most useful sequences in those patients are the thin section, high resolution post-contrast images, and asymmetric enhancement. And often the enhancement is not right next to where the dental manipulation was done. So, we have seen cases where from the maxillary teeth, you can see enhancement anywhere along the course of the V2 segment. We used to see this more frequently in patients who had surgery, microvascular decompression. Do we see just at the site where the surgery was done, or you can see enhancement tracking along the course of the nerves? So in dental patients, the most frequent is you see it in the inferior alveolar nerve. You can clearly see the asymmetry with the contralateral side, not just at the surgical side, but also tracking along the whole segment. So it's very important in these cases to track the whole segment and all the branches of the trigeminal nerve. Because the findings are often subtle, but you can see the clear asymmetry. And again, in these cases, not just the axial images, but doing the coronals as well, especially for the V2 segment, the rotundum segment, those are very helpful.
Similarly, for our MS patients, right, that present with sort of that secondary trigeminal neuralgia. And I'm sure, David, you've probably seen one or two people across the course of your career here or there who have primary trigeminal neuralgia on top of their MS. What sort of things do you look for in your imaging at this point to sort of help differentiate between those two? And I know this is a very super niche, scenario, but it's just something of interest as we're talking about some of the secondary.
Sure. For multiple sclerosis patients, the sequence of choice is a 3D FLAIR sequence. And if you're looking for an acute demyelinating plaque, you want to do post-contrast images, preferably thin section. So routinely for patients, we do both spin echo and a spoiled gradient sequence post-contrast. So acute demyelinating plaques, you expect to see enhancement, not just in the nerve itself, but the nucleus. So especially like the nucleus, and where you expect the trigeminal branches. So we include the cervicomedullary junction as well, just to make sure we are not missing. But the most important sequences, again, are a 3D FLAIR. The advantage of 3D FLAIR is you can reconstruct in different planes. And if there is subtle lesion, and what you're looking for is like a T2 hyperintense lesion, at least 3 millimeters or so, anywhere along the course. The issue with the 3D FLAIR imaging used to be that till a few years back in the day when the techniques were not so refined, there used to be a lot of artifact in the prepontine cistern, like where you would expect the trigeminal nerve to be. But I think a lot of the vendors, a lot of the sequences now that are available, so that's why, like back in the day, we used to do thin section T2 because FLAIR could not be relied on. but I think that has been resolved for the most part. So very few places are now doing thin section T2. The 3D volumetric T2 that we are doing, it's good for the nerves, it's good for anything passing through the CSF, but it's not that great looking at the brain parenchyma itself. So if you're looking for brain parenchyma, that's why you need like a 3D FLAIR, and especially for MS or any kind of a lesion which is involving the nucleus of the trigeminal nerve, the 3D FLAIR and the post-contrast images are very helpful.
Awesome. Well, what are you excited about in this area that you guys are seeing on the imaging side? I mean, I've been excited by the 7 Tesla because it's just, given me, you can really get in there and see what's going on. So that's been really impressive. Is there anything else going on that's been exciting on that front?
Honestly, I've not had experience with 7 Tesla, but definitely look forward once we can get access to those images. We have tried doing some of the things we talked about, like using DTI and stuff. Um, the images look great when we get them well, but the problem is they're not consistent. And I'm quite keen to actually like have a registry like where we can collect patients of where we have follow up. And going back to your question on how frequently do we see non-vascular causes of trigeminal neuralgia, and what's the different spectrum of pathologies which might be presenting as very in a very similar manner, uh, at least in the radiology literature, that has been missing. So I'm very keen to see if we can collect a large cohort of patients and seeing how well the imaging corresponded, or if we need to change our imaging, what are the changes, and for what specific conditions do we need to change our imaging protocols?
Yeah, that sounds like a cool project. I mean, it seems like it wouldn't take that many centers to have a lot of
Yeah.
data.
Right.
Like, I mean, I don't know, we probably do like 100 or 200 whatever procedures, on trigeminal neuralgia a year between the two of us. And, over 5 years or whatever, we probably, and then we have all these other patients in clinic that, maybe we don't operate on. So I don't know, if you had 10 centers, you'd have
Right.
huge, maybe 10,000 or
Right. And
10,000 patients to pull. Yeah.
as I said, on imaging, many patients, despite an extensive imaging workup, you don't really find a cause.
Right.
So are we missing? So like I said, in a few cases, and the only reason we ascribed it to idiopathic intracranial hypertension is when that was taken care of, the patient's symptoms got significantly better.
Right.
So how frequently is that happening again? It's something not very widely reported in the literature, and needs a follow-up to see like, are we missing those? Because we are giving contrast, should we be looking for signs of intracranial hypertension? Some people have also looked at the morphology of the Meckel's cave, the volumetric studies of the Meckel's cave. But again, those have not been a part of the clinical realm.
Right. Yeah, I guess the challenge on our side is, like, I think we could get centers to, share data and some de-identified data, but the hard part is it's really hard to de-identify MRIs with the face for when you're doing
Right.
trigeminal neuralgia.
Right.
Although I guess we could just not include the face, because most of the stuff that people are going to probably do is not that big a deal. And if we do have a lot of volumetric data, then it's like pretty nice. I think it could be analyzed pretty well, and maybe there is, like, I keep seeing all these people being very seemingly publishing very successful papers with the use of AI and volumetric imaging. So
yeah, I was going to say, like, some of the tools that we have now available, what used to be a very manual, very tedious task, can be automated, can be made much faster and more consistent, because it's not as dependent on someone drawing ROIs, like you're talking about DTI. So
Yeah.
definitely, like with AI, a lot of the things which we never came into clinical practice probably need to be relooked.
Yeah, I think that's probably, having a trigeminal specific AI that really can pull all the sequences together and look at the secondary, really try to give you some score for secondary causes, and that in addition to, looking at the nerve, I think would be really cool.
Yeah.
And maybe it could be trained in 10,000 scans. I mean,
Definitely.
I don't know. That back in the day, I wrote a paper with my chair, Steve Haynes, who was one of Janetta's students, and the whole study was that everybody sort of could claim that they could see and characterize neurovascular compression so well on their own, but whenever I compared it with anybody else's readings, they are never the same. so I got like 100 scans of trigeminal patients, and then I used the patients that were getting the IAC workup as the controls, because I could cut and sort of set up the scans the same way. And it turned out that it was random chance agreement between a couple radiologists and a couple neurosurgeons.
There is that's absolutely true. There's a lot of variability. The vendors have gotten better, the sequences have gotten better, but the interpretation of those images has not reached the level of standardization that the image acquisition has.
I think so. Yeah.
Images have gotten better, but from the radiological perspective, there needs to be more of a better understanding of just a vessel next to the nerve does not mean there is a vascular conflict.
And maybe, that's one of the real benefits of a registry like that, I think, is to develop the educational curriculum to say, let's train you on the first 100 scans, and here's the most variable 100 scans, and have someone walk through every single one of the scans that have already been vetted and there's high agreement about. Because I think that's the challenge, is no matter where you train, you're subject to the training bias of your institution and the people who are there. But, this is some way to sort of, bring some equity to, how people are understanding this, these reads.
And I think some of the secondary questions that come out of that are sort of interesting, because if you have, because obviously you'll have outcomes data from this, what does it mean for the patients who didn't see success with MVD or, balloon or glycerol or what have you? And are there imaging characteristics that they have that we are just not seeing with the naked eye in terms of our evaluation, because we're looking at it individually, case by case, right?
Or we're not paying attention to the
that's, I think,
joint.
An important question as well.
Yeah.
Again, that's something which is missing from the literature also. Very few studies have actually gone back. The failed cases, were there imaging findings which explain, or what else was needed from imaging? Again, imaging may not give all the answers, but sometimes it does. So people have not really gone back and looked at the images to see if they missed something, or if there was a specific cause which could have been addressed.
Yeah, that's cool. All right, so we're developing a registry of failed MVDs. Maybe that's it. All right.
Worth looking at, yeah.
I think we lost you, Vishal. Are you still with us? Oh, there you are. Okay. Awesome.
I'm still here. Yeah. Okay. Yeah. I think I'm not sure. The internet's been acting up a little bit, I guess.
No worries. Awesome. I think that's all I had. We really appreciate you coming today, Dr. Malhotra. It's so helpful to have sort of these interactions sort of at the society level, because, I get to interact with my radiologist, but we don't ever talk about sort of, what's going on at that higher level, what you guys are thinking about. So it's really helpful to hear that from you today.
Thank you for having me. This requires how we are doing imaging, and if we need to improve our imaging, absolutely relies on feedback from you guys. So what would you like to see? And again, it's a collaborative, and I think having a registry, or at least going back and collecting patients, whether it's a prospective registry we are collecting, or going back and looking at, say, the failed patients who still have symptoms, I think that would be very helpful in refining and improving our imaging further. And again, like you said, what's really needed from the imaging side is more standardization, better training, because the imaging has improved, the accessibility to those imaging has improved, but the interpretation of the imaging needs to be more standardized.
Totally. I love it. I love it. Maybe we can turn this into a inter-society registry. I think that would be super cool. And I bet a lot of people would be interested. I know, I mean, just from a practical perspective, there seem to be more and more of these sort of cancer registries for imaging specifically. So maybe there are already sort of platforms set up to make that very feasible, you know, for us, where it's not a huge, you know, cost, and it could be like fellows and resident project that turn out to be really powerful.
Yeah, would definitely love to explore that. Like you said, ACRN for tumors and all, ACRN registry has been collecting data, but doing something similar for trigeminal patients would be very helpful.
Definitely. David, quick question. For our PICOs, do we have scope covering sort of recurrence and surgical management thereafter?
We do. Yeah, we have that.
So I guess one final question I had for you, Dr. Malhotra, is what imaging recommendations do you have, or things that we should be looking for those patients who have failed, say, MVD, and we are considering reoperation or looking at other potential therapies? What things should we be keeping an eye out for on the imaging side?
So again, in addition to the sequences we talked about, I think very helpful is looking at the post-contrast, thin section post-contrast images. You know, when we scan the routine brain, we are doing the regular, the 3 millimeter and the spoiled gradient sequence, which is the volumetric sequence. But in this case, if you are looking specifically at the site where the MVD was performed, or we have seen also the enhancement extends along the branches of the trigeminal nerve, not just at the site, but like more distant from it. So in these cases, looking at the post-contrast images, what we do is we acquire 3 millimeter small field of view, 16 centimeter field of view, high resolution images, both in the axial and in the coronal plane, to assess the enhancement at the site, but also to cover the different parts of the trigeminal nerve. And I think that's the surgeons have found very helpful.
Yeah, that was a great question, Vishal. Awesome. Yeah, I totally forgot about that.
Nice.
Great.
Awesome. Thank you.
All right, thank you so much.
Okay.
We really appreciate your time. It's fantastic. Thank you both for volunteering your time.
Thank you. Look forward to working with you.